Hi, everybody. I'm Bill Sage. I've been a visiting professor in the law and medical schools at NYU for this very unusual academic year. My normal job is I am a tenured professor in both the law and the medical schools at the University of Texas at Austin. And I do a lot of work in various aspects of US health law and health policy. Which I thought I would talk with you about today. So the title of the talk is COVID-19 and US health law, emergency change or system reset, because undoubtedly you have either heard of or participated in the efforts that are frantically underway right now to modify various legal provisions, mostly state, some national, in order to deal with the ongoing pandemic. And so I've kind of given you a little list of the sorts of things that many states are adopting through various legal mechanisms, often echoed at the federal level, sometimes done through voluntary arrangements with private providers and payers, which we'll come back to momentarily. Several governors have suspended elective procedures in order to save space and PPE and staffing for dealing with COVID-19 patients, as well as to protect patients who are uninfected. There's been a very sizable movement to suddenly expand the scope of authorized practice for various health professionals. This is a phrase that is finally being recognized, which is to allow these individuals to practice, quote, at the top of their training and their skills. I just sort of remind you that often in the rhetoric they talk about practicing at, quote, the top of their license. Well, that's a bit of a tautology, because if their license is restricted in a particular state, the top of their license isn't really very high. We're finally talking about the top of training and skills. Also associated with advanced practice nursing, physician assistants, and others, a lot of supervision requirements that have required direct physician participation in these individuals' professional practices have been suspended or waived for the duration, usually of a declared emergency in the relevant state. Telemedicine and telehealth are now much more liberalized from the perspective of state laws permitting them as part of professional practice, and often even as in terms of their coverage status under public and private payers and the associated payment for their services. Out-of-state physicians and even physicians trained in foreign countries are being licensed in US jurisdictions. Retired professionals are having their licenses reactivated. New graduates are being rushed into the workforce through various forms of licensing acceleration. At the facility level, all sorts of compliance requirements, particularly on the skilled nursing and long-term care side, have been waived or relaxed. And on the private liability side, various states have adopted broad civil immunity statutes to facilitate COVID-related care with various types of exceptions. To the extent that it's been feasible through law, insurance regulations have been liberalized, and sometimes Medicare and Medicaid conditions of participation and their coverage and payment rules have changed. And what I want to really spend the talk on is what this all means. Is it working, and is it important beyond the time of the crisis? I'll give you just a quick example. This is a provision that got sent to me coming out of Texas for Texas's Medicaid and SSI-related community-based assistive services. I show you this not to say that this is the most important of these emergency modifications, but to show that even lawyers have both common sense and a sense of humor. These are the services that are now permitted to be provided by telehealth, and fortunately, these are the services that are not permitted to be provided by telehealth. You may not have massage therapy, therapeutic horseback riding, or aquatic therapy by telehealth, and I'm very glad to see that. On a more serious note, it's well recognized that there are many benefits to taking a more permissive approach to health professions licensing: educational opportunities, accessibility and cost of care, average quality of care if you average the people who get the permitted treatment with people who might not be able to get any treatment at all, and then various sources of innovation. And the reason this is important to show you is that this is not my list of potential benefits. It's not even a recent list. It's actually Milton Friedman's list from 1962, which makes the point that people have been thinking about liberalizing these laws for a very long time, and it really hasn't happened, and it certainly hasn't happened quickly. So to the extent it's happening as a result of the COVID-19 pandemic, this is something that may be, have greater long-term value in the system. We are seeing many legal frictions as sort of the nature of US health law gets revealed in the pandemic, particularly around COVID testing. We're finding federal regulatory agencies that are at cross purposes with one another. In general, as we'll talk about momentarily, the division of authority in US health law is that state laws regulate the substance and federal laws pay the bills. The same way Governor Cuomo today just talked about the federal government passing the buck to states without passing the bucks. There have been various problems with federal funding for the legal response to the pandemic. There are examples of residual protectionism. For example, one state where there was a very significant delay in authorizing physicians from other states to provide telemedicine services because the in-state physicians only wanted to allow that if the services being provided from out of state were specifically related to COVID care, which kind of is, the point of having interstate telemedicine is to help patients who are not infected with COVID and need care that can't be provided within the stressed existing system. So this residual protectionism is a problem. A big problem is that states and even the federal government in many instances doesn't have legal authority over the many private bodies that govern coverage and payment. Another problem is sort of revealing the longstanding frictions between the health law infrastructure and sort of the general regulatory infrastructure. Occupational safety and health protections in long-term care facilities, for example, I think are far below what they should be during this time of crisis. We've seen many instances in which the system's reliance on private supply chains causes legal frictions, including not just sort of things like PPE, but the proper disposition of human remains in a situation such as the one we face these days. We have various folks who are either overtly or at the margin exploiting the existence of the crisis, creating issues of public protection and enforcement. People out there marketing unsafe or ineffective COVID tests. One of the biggest problems is that something like a public prohibition on elective procedures really goes at odds with the way much of our healthcare system operates, which is sort of through private processes that generate substantial revenues. And it's not just that the patients need these services, it's that often healthcare organizations cannot be financially viable and may lay off very well-trained professionals and other staff who really want to contribute, but they don't have the revenue going through the organizations in order to do that. And that's really, I think, an indictment of our system more than anything else. We're not showing that we have sort of good legal protections and support for workforce, particularly, say, low status health workers in long-term care facilities. And we've seen that we have a lot of gaps in our information infrastructure, because so much of health information exchange is really just geared to the task of being paid for one's services. And this is not the moment when that type of information is most important. Here's a recent graphic from Joanne Spetz's Health Affairs blog post a couple of weeks ago that makes the point about sort of where our very well-trained, professionally committed nursing workforce actually works. And you can see from the pie chart that well over half of the nursing workforce is not in the settings that would be most likely involved in continued revenue generated medical care. 1.3 million nurses working outside hospitals, another 500,000 working in hospital, ancillary, and ambulatory facilities that may not be operating during the pandemic. This is a sort of a loss of, it's an opportunity cost for professional skills. It's a sidelining of very well-trained people, and it's an enormous economic challenge to the system. It's not just the economy outside healthcare that's challenged by the pandemic, it's the economy inside healthcare. And this connects to a broader point, which will bring us, I think, back to law at a very deep level. Everyone knows that in an international comparison, the US spends more private money per capita than any other country. I mean, gobs more. But the US also spends more public money per capita than any other country. And I sometimes, recognizing the oversimplification, characterize the US healthcare system as a giant money laundering operation. Where we take a number of public functions and we finance them through private mechanisms, because explicitly committing to the public investments is very hard at a lot of levels, political, fiscal, and otherwise. And so what we've actually created in terms of governance is a system where roughly equal and very large amounts of public and private investment are governed largely through the same sets of laws and the same sets of professional self-regulatory bodies. You don't need to understand this diagram. The point is that there is a very strong convergence between what we consider public investment in health and healthcare in the United States and what we consider private investment. It really is all one system, but it largely runs on premises that are associated with private professional therapeutic relationships. I often describe the system as basically constructed around a mental image of a therapeutic relationship between sort of an idealized physician and an idealized patient. And then laws put in place that protect and subsidize that dyadic relationship, and then scaling those up to the population level and kind of declaring that that's a healthcare system. And I don't think that's a mischaracterization of really what we experience over the last 100 years or so. Most of these laws are state laws that confer privileges on the professions and their therapeutic commitments to individual patients. And since the passage of Medicare roughly 50 years ago, it's mainly been federal law that funds the system that state law created. And I'm not going to try to go through all these categories, but the point that I want to make against the backdrop of all of these emergency legal modifications for COVID is that there are many domains of law that reinforce, very strongly reinforced characteristics of our existing healthcare system, and they're pervasive. They're not associated with one political party. They're not associated with one health reform moment. They're laws that have accreted over a very long period of time, but they lock us into a system with various characteristics, and many of the failings of this system, if they haven't been revealed before the pandemic, have been revealed during the pandemic. And the ACA, which I very strongly support, never really took this on directly. This is a quote that I use a lot in my teaching, though I don't know if it's really been circulated otherwise. This was what President Obama said in the Rose Garden of the White House in 2015, celebrating the second major Supreme Court victory for the ACA. in the King versus Burwell case. And without reading the entire quote, the point is that as far as the Obama administration was concerned, it was important to defend the ACA on an individual consumerist basis. And to push back strongly against any sense that there was sort of a collective interest here or a statement of participation in healthcare as citizens through the avenues, the vehicles of government. There's no card that says Obamacare, but that's by design. The reform is rules and protections that make healthcare more affordable, more attainable, and more about, at the end, the consumer, the American people. And this equating the American people and their health and healthcare needs with consumers is a very limited, if perhaps politically necessary, approach. And I've always said that there was no AmeriCare at a time that we really needed AmeriCare. And so what I'm trying to convey is that the legal infrastructure of U.S. health care is really constitutive of the system we have. And many of the policies that we either celebrate or struggle with, depending on the time and place, are consequences of the laws we've put into position. And therefore, the sorts of revisiting of those laws we're doing now are very important. And here's some of the longer term issues that we can deal with. Or attempt to deal with. First of all is just disrupting that antiquated legal infrastructure. Coming from Texas, I often describe this as the project of fracking the healthcare system, breaking up these laws to have a system that performs better going forward. We've seen in this particular COVID crisis, very strong interest in protecting civil liberties, but also threats to civil liberties. And this is not just government in its police powers, but it's also the private norms that government policies express and reinforce. And so, I have great concerns about privacy and stigma and discrimination coming out of the pandemic. I think we've seen in the pandemic, and this is very welcome, that there really is an attention to communities of color, to social determinants of health, to healthcare disparities. We've seen this a lot in the way in which the horrific prospect of rationing life-saving treatments such as ventilators has come into public discussion, where we actually recognize that what even a couple of decades ago seemed as sort of a neutral medical criterion for prioritizing one patient over another is very likely to reflect a long history of disparity and racism and population-based lack of opportunity. And the people who are sickest today are not sickest because they're sickest because society has made them that way. And these are major legal questions that we can think about. And I think, what we need to do over the next several months as we work our way through this is think about, the legal changes that we've made that we should continue. I believe in the staffing flexibility, the changes to scope of practice, the geographic flexibility, the recruitment of technology through telehealth. I think we're starting to think about providing the safety supports and resilience supports for our healthcare workforce, something that's been greatly neglected. And reducing some of the narrow compliance bureaucracy that we've suffered from. It's amazing if you look through any single state's revisions to its long-term care protections, how detailed those are, which really suggests that the model for long-term care regulation needs to be revisited. There's other things that we need to revisit at the systemic level that I think are even more important in terms of getting us out of a sort of revenue model for our system based on reimbursable claims. We've been enacting these liability protections, but I think we need to recognize that it's not a question of immunizing the healthcare system. It's a question of establishing best practices for safety and for response to error. And I'm low on time and want to leave you opportunity for questions, but I think there are many things that sort of arise from these legal changes that we'll want to consider over the future, and many of them really reflect generational change, both in the recipients of care and in the providers of care. And I really can't resist just showing this one quote from Bob Wachter, now chair of medicine at UCSF. He tells this story himself about lecturing to first-year medical students. And he and I were in medical school roughly the same time in the 1980s. And here he is, lecturing in the 2010s. You folks are entering a profession completely different from the one I entered 30 years ago, because you will be under relentless, unremitting pressure to figure out how to deliver the highest quality, safest, most satisfying care at the lowest possible cost. And of course, being today's very smart medical students, a hand goes up. Well, excuse me, Dr. Wagner, but what exactly were you trying to do? There's opportunities. There's opportunities for younger generations and all of the health professions to really approach things differently. And I think the legal changes are going to be part of that, eliminating the things we have suddenly found ourselves willing to eliminate and revisiting things that provide residual frictions. I'm going to leave this alone for now. And sort of where I'm heading is that this is an ethical realignment as well as a legal one, that the professional role here as well as the public one are both very important. And if we do this right, we might have a nice sunrise. We had a terrible storm. This is where I'm sitting right here up in the mid-coast of Maine. And we had a terrible storm on Monday night. And I got up early Tuesday morning before dawn, and I walked out on the beach and I took this picture. So I will give you this picture to end the talk. Thanks.
Thank you, Professor Sage. We're now collecting questions via the Q&A function at the bottom of your screen, so everyone can please submit your questions. Our first question is from Julie, who asks, what do you think some of the measures will be to confirm health among the population? And what liberties will we be willing to relinquish in order to resume public activities, somewhat like screenings at airports?
Well, I think this is it's obviously a very good question. I think we don't know yet. I think we're all hoping for a technologically driven fix. And I think, what we'll be experiencing is much more of a socially driven fix. We will have some testing technologies, we'll have some tracing technologies. Hopefully, we'll have some, back pocket therapies that will allow us to take somewhat more risks than we otherwise would take. I think, personally, I think what's most important is that we treat one another with respect as we do this, and that within the healthcare system, we try to internalize some of the lessons that we claim to have learned about inequities, about hierarchies, and not be judgmental. I think ultimately there's very little that governments are going to do that is directly coercive in the United States, because direct coercion often is ineffective. I think this really is about the formation and the enforcement of private social norms, and then what one might call the law's expressive role in either reinforcing those norms or, when necessary, pushing back against those norms as they evolve.
Great. Our next question is from Lisa, who asks, in regards to the issue of rationing, should we use the law to set the parameters for resource allocation and priority setting, or use law to create infrastructure to address resource allocation and priority setting? So
the rationing conversation has been a really interesting one for me to see as I've engaged this. And this is, I'm not in the middle at the front lines in the settings where this has become most acute. Over the longer term, we have regarded most direct government intervention in healthcare as an invitation to coercive rationing. at a time where, frankly, very few things ever really needed to be rationed because there was so much inefficiency and unfairness in the allocation of very generous resources that rationing was more a rhetorical concern than a real one. We're going to have some real resource constraints because of economic contraction, because of the strains on the healthcare system, because, frankly, the political tolerance for fiscal expenditure in this country is limited and somewhat unpredictable. You never know when people will all of a sudden refuse to stop spending money that they should be spending. I think in terms of, physical scarcity, I'm hopeful we won't have to confront too many of those situations. I think what we've learned so far, though, is a couple of things, is that it's never going to be effective for us to have absolute exclusions. If we need to prioritize everyone, every individual who might have a claim on a life-preserving resource should have an opportunity to individualize that claim. We shouldn't have rules that say, because you are this or that, or not this or that, you don't get a shot at it. I think we've learned that. What type of process evolves? I actually think there's no way to determine that from the top of the system. It's something that will come organically, and I hope not destructively from within the system. I would like to empower younger generations to have a voice in that within the settings where it's necessary. I think just looking to one's seniors, as is conventional in sort of certainly physician training, is not a good indication of how to deal with those extremely difficult decisions. But I think that's going to be much less centralized than one might think.
Thank you. Our next question is from Vivian, who asks, what are the potential challenges in keeping the current temporary legal changes in the system moving forward?
I think actually this will break certain log jams. I think teleservices will find themselves a much more secure footing as we emerge from the pandemic, and the laws that constrain them will not be resurrected. I think many of the issues around professional scope of practice also will have, they've already outlived their usefulness. I think most of those will also, survive in a liberalized form. I think something one has to be attentive to is that insofar as there are financial strains within the healthcare system, there are going to be people who are financially motivated to protect or reclaim their turf. And I don't think one can fault them for that, because these are going to be very lean times for some people. But I think, that's something we should be alert to. Overall, I think the likelihood of keeping these laws in place beyond the emergency is substantial.
Great. Our next question is, where can the line be drawn on what procedure is strictly elective versus an emergency procedure?
I don't think the line can be drawn. I think it's very context specific, and everyone's care is important to that person. And I think what I believe is that the same types of sort of testing and voluntary separation and delay proceedings that will allow us to re-engage in the non-healthcare parts of society will also help us re-engage in the healthcare parts of society. I do think, and this is perhaps a little controversial to say, but I think it's important to say, our system, sadly, is so based on private revenues for services that are certainly useful to the people who receive them, but generate sort of reimbursable claims through insurance payment. I mean, so much of our system depends on those services that I think we will have no choice but to at the margin, allow our healthcare facilities and professionals to do more rather than less, rather than, take the very strict route of, no elective this, or, this is not a sufficient emergency. I think beyond the needs of the patients, and the patients' needs are, of course, incredibly important, I think that we're risking some serious destabilization to the way our system is constructed financially, unless we allow many of our healthcare providers to start generating revenues for themselves again. I know that's a little controversial to say, but I think it's one thing that is actually missed in the system when people think about it.
Thank you. Izat asks, will there be accountability for the lives that may have been saved if the government had acted faster? In other words, is there a ground for malpractice on a whole scale?
Well, let us hope we have democratic processes in place so that we can have political accountability for decisions that cost lives. I don't think there's anything within sort of the civil liability system around medical negligence at either the professional or the facility level that is going to be triggered for the things that I've witnessed so far. These are broader system failings because of lack of public engagement. And, I certainly hope that there will be attention to public compensation funds for people who have suffered and lost lives as a result of public failings. But I don't think that this will go through sort of private legal processes.
Got it. What do you recommend reading during this time to follow the changes in health law and policy? Are there news outlets or specific people you recommend we look to during this time?
I mean, there's so many sources right now. I tend to think, if you're working in a particular setting where it's absolutely essential that you know what laws govern your setting, then you're going to do focused research and hopefully have the support of your organization or your professional society. If you're looking for a landscape, I actually think you can learn a lot just by browsing a particular state that you might have some connection to or interest in. Look and see what executive orders the governor has issued. Those are usually online in a list. Go to the website of the 2 or 3 state regulatory agencies. They'll show you that. At the federal level, the FDA or CDC or FEMA will show you some of the legal changes. I actually think, because most of us just see small parts of the healthcare system, that the browsing function is useful here. You'll kind of notice what's relevant to you, and you'll notice what other categories are represented. I think it's too early for most people to be doing synthetic writing about this. I have to say, this is an area of particular interest to me, but the long-term effects of the collective of U.S. health law and the way our system works is not something that has attracted a lot of scholarly attention over the years.
Great. Thank you, Professor Sage. So we have time for one more question that we've been asking our WAGTalks speakers. What gives you hope and optimism during this time?
I think just for me personally, it is very frustrating to see systems of government who should both deserve and have our trust neither deserve nor have it. And I take that personally as someone whose career is devoted to law and public policy. But I am generally optimistic because there are so many committed people here who are really so attentive to their own relationships and their own community and the greater good. It has been extremely heartening to see the response of health professionals called on to volunteer. I would just say that I do have, one small caution that goes with my optimism, which is I think that health professionals are often drawn to sort of a model of the hero. And I think that most heroes are made, not born, and you can't rely on heroism to get you through the crisis. We do need to have some organization, some support. This won't be done just as sort of individual heroism, but I think, organizations, communities, cities, towns, churches, states are stepping up, and we can come through this.